Hi there, everyone. So welcome. I believe everybody can see my screen here. This is the 12 o'clock to 12:50 oral presentation specifically on evaluation and assessment. And we've got 5 presentations. My name is Quang No. I will be your moderator for the session today. Just a few quick little housekeeping issues. Number one, just if anybody has any questions, please type them into the chat. I will monitor that. During the Q&A itself, you could please just make sure you raise your hand, and then I will call on you to ask your question. While we're listening to the presentations, if you please keep your video and audio off during the presentation, that'll just help with bandwidth issues. Each presentation is supposed to be 10 minutes long, and that's a combination of both presentation and questions as well. So I'll just be keeping everybody on track. And then by the end of the session, which ends at 12:50, we'll have everybody head back over to closing remarks, as there won't be any break at the end of that, okay? If you'd rather not raise your hand and ask a question, you can also, again, type in the chat, and I will be happy to ask the question on your behalf. Any questions, concerns, comments before we begin? No? Okay. I will be controlling the screen, so I'll scroll down to the slides. But why don't we start with our first presentation. So this is Global Perceptions on Social Accountability and Outcomes, a survey of medical schools. And I believe Saad Shaheen, oh sorry, our presenter is Cassandra Barber.
Hi, everyone. Can you hear me okay?
Yes, we can.
Okay, great. I just can't see my my poster. If you are able to scroll down. Okay.
Is that there? Can you see that?
No, I can't. I don't know if it's just me.
Yeah, we can't see either.
Okay, good. Thank you, Anita. Okay, it's coming. I can see some of it now. Like it's kind of like split in between. There we go. Perfect. Thank you. Okay. Thank you so much. Oh, now I can't see anything. I don't know if that's just me.
I will screen share. Oh, okay.
Okay. Oh, okay. Perfect. Thank you. Okay. Thank you. I'm Cassandra. Welcome, everyone. It's a pleasure to be here today. I'm a PhD candidate at Maastricht University, and today I will share some findings from a survey study I conducted as part of my dissertation, investigating global perceptions of social accountability. As we know, social accountability has become a universal component in medical education. However, how these initiatives are implemented in practice remains elusive. This study explores institutional practices and administrative perceptions of social accountability in medical schools. So we derived an online international survey on social accountability comprised of 41 items related to program mission statements, admissions processes, curricular and educational outcomes. These items were derived using previous literature and categorized using a program evaluation model as our organizational framework. Following an expert review process, the survey was then distributed to a purposeful sample of academic deans from English-speaking undergraduate medical programs from 245 institutions across 14 different countries between February and June of last year. Survey data was then analyzed using exploratory factor analysis to assess the interrelationship among survey items, and reliability analysis was used to evaluate the internal consistency. So a total of 80 medical schools across 14 countries completed the online survey, representing a medical response rate of 30% and an individual response rate from undergraduate deans and/or delegates of 9%. In terms of respondents' demographics, approximately 55% of all participants were males and 45% female. 3/4 of all respondents self-identified as medical practitioners, reporting the number of years in practice ranging from 5 to 43 years, with a mean of 25.8 years. Additionally, the number of years respondents reported working at their current institution ranged from 1 to 35 years, with a mean of 12.6. In terms of institutional characteristics, Many respondents reported that they believed their institution had a primary care or family medicine department or faculty. And all respondents reported having learning opportunities in hospitals and outpatient or emergency clinics, as well as within a physician's office and in community health settings. However, fewer reported offering learning exposures within patient homes, elderly care homes, or chronic care facilities. When it came to social accountability perceptions within their institutions, all respondents expressed a high perceived importance of social accountability. And interestingly, 88% reported that their school has an explicit social accountability mandate to serve the priority health needs of their local populations. Institutional practices of social accountability were captured using 28 Likert scale survey items. So these items were measured using a 5-point agreement scale, 1 being low and 5 being high. The reliability estimates of the overall variance in the Likert scale items were very high, indicating excellent internal consistency. However, the means and standard deviations of these items varied. For example, item means related to institutional mission statements and community engagement ranged from 4 to 4.6. However, item means related to whether programs coordinate with local organizations to promote healthcare, produce the right number of specialists needed to serve workforce needs, or collect data on the impact of graduates on patient outcomes were significantly lower, ranging from 2.6 to 3.8. Next, we conducted our exploratory factor analysis using these 28 Likert scale items. The number of factors to be extracted was determined using several criteria. The ultimate solution comprised of 5 factors, accounting for approximately 68% of the total variance in the items. So based on our EFA findings, names and alignments to the program evaluation models were identified for each factor. All internal consistency reliability values were acceptable at greater than 0.05. 3 of the 5 factors aligned to input evaluation. These included items surrounding institutional mandates, selection and recruitment, and community responsibility. 1 factor aligned with content evaluation. These included items surrounding community partnerships and engagements. And the last factor aligned to process evaluation, which included items related to curricular activities. So unfortunately, items related to product evaluation, for example, graduate outcomes and impacts on community health, were not captured within the EFA. So using data collected from 80 institutions across 14 countries, this study represents, to our knowledge, the first international consensus and validity evidence on social accountability perceptions and institutional practices, linking theory to practice. So findings from our EFA suggest that the emphasis of social accountability institutional practices focus predominantly on the use of narrow practices, such as the adoption of select internal policies related to educational inputs and processes, rather than evidence related to educational product outcomes and impacts. However, these findings are actually consistent with previous literature, in that while most respondents express an institutional commitment to social accountability, the effects of their outcomes on the community remains unknown and are not evaluated. Overall, the lack of emphasis placed on community impacts may suggest that perhaps the perceived institutional practice observed from this study better represents acts of social responsibility and responsiveness, and not necessarily those of accountability. Further research is required to identify meaningful relationships or proof of concepts to link educational policies and activities to outcomes and explore the extent to which these practices have on community impacts. So thank you everyone for listening, and I look forward to hearing your questions.
Thank you very much for that. Can I ask, are there any questions from the audience, or anybody want to type in questions in the chat? Maybe I can start by asking a question, and I don't know. You asked specifically, you surveyed English-speaking undergraduate medical programs. Do you get the impression that there's a difference in social accountability and interpretation or outcomes in international audiences?
Yeah, so that's actually a great question, and something that my committee and I, discussed in detail in creating these survey items, and conducted a lot of external review process with experts to ensure that the language was kind of more universal. And so it's interesting because we only focus on English speaking schools because a lot of, especially I think, practices and just simple linguistics are lost in translation. For example, in French, there is no word for social accountability, it's social responsibility. But I do think it definitely varies. And from what we found, within our study is that how people interpret social accountability, although there's an international, generally accepted definition of social accountability, it's often left to interpretation.
Great. Thank you very much for that. What we'll do is we'll move on to the next presentation. Thank you. Our next presentation is an evaluation of point of care or POCUS training for midwives. And our presenter today will be Bronte Johnston.
Awesome, thank you so much. Can everyone see and hear me okay?
Yes.
Yes.
Great, thank you. So hello everyone, my name is Bronte, and today I'm going to talk about my thesis regarding the impacts of point of care ultrasound training for midwives. So for a bit of background, this project came about with the 2018 College of Midwives of Ontario scope expansion, which allows midwives to perform ultrasounds with appropriate training. So point of care ultrasound, or POCUS, as I'm going to refer to it moving forward, is an ultrasound scan performed by a health practitioner who is not a sonographer. And in a recent Ontario Midwives Needs Assessment, it was found that there's a desire for ultrasound in the midwifery profession because they felt it could provide more holistic and better client care. And with that, a course was developed between McMaster's Midwifery Education and the McMaster Mohawk Medical Radiation Sciences program, with its first cohort starting in fall of 2019. So the research question for this project was, for Ontario midwives, what are the educational impacts of this POCUS course? So as this is an education-based project, we employed the Kirkpatrick model to evaluate learning through a 4-level framework. So briefly, levels 1 and 2 refer to participants' thoughts about the training, while learning is the increase in knowledge. And levels 3 and 4 focus on deeper learning with regards to how has the curriculum changed our participants' behavior, such as how are they using POCUS within their practice, how has it shifted the midwifery profession. So our methods were triangulated and were collected concurrently, but analyzed separately, and were then compared and combined to generate a rigorous evaluation. So quickly, they included 5 semi-structured interviews, which took place in spring of 2020, as well as 4 surveys, which contained both 5 and 7-point Likert scale questions and open-ended responses. And these surveys spanned between pre-course to 1 year post-course. Additionally, our research analyses used descriptive statistics and grounded theory methods for the quantitative and qualitative results, respectively. So overall, we found 5 major themes of facilitating learning, improving care, addressing barriers, refining the role of the midwife, and serving community. But for the purposes of today, I'm just going to talk about 3 themes based on their relevance to education and education-based theory. So one of our goals of this course was to facilitate sonography learning to our participants. A major motivator described by them to attend this course was their inherent excitement for learning. Participants' clinical and theoretical sonography learning was facilitated through 3 different education methods. So a series of online modules, a 2-day workshop, and a clinical practicum. Provided the minimal experience or understanding our participants had of POCUS prior to this course, they needed to take a significant amount of time, more than expected for some, to understand sonography basics. Some participants also thought that the quantity of the didactic information they were expected to know before the workshop was overwhelming. However, they expressed a lot of gratitude and felt that they benefited a lot from the hands-on ultrasound training during the workshop because they found acquiring the clinical sonography skills very challenging. So for example, one study participant mentioned how they had difficulty connecting the didactic material to the clinical skills in the workshop. They found it quite challenging to recreate the images that they had seen in the online modules. Additionally, the clinical practicum was seen as an essential opportunity for continued ultrasound practice and for participants to ask further questions to refine their POCUS knowledge and skills. For those who were able to obtain a clinical practicum or had access to an ultrasound device, described themselves as being generally competent as they were repeatedly able to conduct POCUS scans for different indications, such as fetal presentation. However, some learners struggled with determining their competency level because they felt that competency was challenged to determine, and I quote, "Obviously you have to do some volume," in reference to the number of practice scans to maintain competency, but competency is not only based on volume. Additionally, throughout the course surveys and interviews, there were several comments on how participants' POCUS learning was hindered by the costs associated with the course and also a device, as well as some personal issues. And as a result of these barriers, only 56% of our survey respondents stated that they were using POCUS in their clinics. The costs of the time that they needed to invest for this training was significant as well. Many participants shared their difficulties with the clinical practicum and struggles that were only heightened by the COVID-19 pandemic. Several participants mentioned that they had tried to organize a practicum, with some reaching out to clinics that were hours outside of where they were located, but they couldn't find one that had room for a midwifery learner. So while there's no clear solution to how to improve this clinical practicum access, especially in a pandemic, it is something for course coordinators to think about to try and solve these issues. For example, it may be helpful for course coordinators to reach out to sonography clinics and work and collaborate with them to have more opportunities for future learners. So midwifery is also a profession that is continuously evolving to provide optimal client care. However, throughout the interviews, comments were made about the public's generally minimal knowledge about midwifery, and participants felt they required proof of certification to validate their POCUS skills. So at a health policy level, participants reported that midwives are generally underused in healthcare systems and that policymakers have minimal knowledge of their clinical capabilities, which unfortunately leaves them out of policy decisions that impact perinatal care. So not only would POCUS education not only expand their skill set, but hopefully it would allow the public to understand their extensive training in the perinatal period as well. Additionally, 78% of our participants shared that they were going to continue using POCUS in their practice at the end of this study, highlighting the shifting role of a midwife in our communities. And the clinical indications that were most frequently used and thought to be the most beneficial for midwives throughout the surveys were assessing fetal presentation and confirming viability of the first trimester. So how does this connect all back to the Kirkpatrick framework? Well, the results I shared today actually connect to all 4 levels of this framework, with how participants felt and learned POCUS skills, as well as the upper 2 levels of behavior and impact. Consistently, we saw how POCUS had changed our participants' clinical behavior and shifts in the standard of care of how they would use this technology in their clinic. So overall, this project illustrates the importance of POCUS in midwifery and understanding midwives' acquisition of these skills and the benefits of applying these new skills, indicating the merit of this education. Thank you.
Thank you very much. That was very enlightening, especially moving towards expansion of skills. Can I ask you, are there any questions? Just monitoring the chat as well. I was going to ask, I mean, we draw sometimes in medicine, in emergency medicine, POCUS took a while to take off as a skill set. And there was a lot of resistance, for example, from radiology to allow emergency practitioners to use it. Can I ask you to maybe elaborate on what the midwives thought were going to be the biggest barriers to owning some of this skill set more?
Yeah, so I think that kind of touches on a point that I talked about how they feel like they require proof of certification of their skills. They felt that because the public has minimal knowledge of midwifery, they wouldn't expect them to have this knowledge or to be able to use this technology. And just a quick comment as well on sort of the pushback between other healthcare practitioners, such as radiologists. I think the important thing to recognize and to really educate as well in POCUS is that this does not replace any sort of diagnostic imaging. It's simply used to help enhance their clinical care and clinical decision making. So a lot of times people can get confused that POCUS is a diagnostic scan, but it is not.
Gata has a very interesting question, but I may ask, I may send that to you personally, but just coming from the imaging field, how do you ensure that knowledge, skills, and judgment is attained with the limited didactic completion? Just for the interest of time, I'm going to copy that question and then I'm going to paste it directly to you. And that way the two of you can continue that conversation. Okay.
Great, thank you.
Yeah, but thank you very much. That was very, very enlightening. Okay, so why don't we move to the next presentation. So what we've got right now is Megan Furnival is presenting Midwifery Student and Resident Understanding, Learning, and Application of Shared Decision-Making, a Grounded Theory Study. Let me just see, I just want to make sure that everybody can see this. This one's a bit bigger.
Perfect, thank you. Hi, everyone. So I think it's safe to say that midwives and obstetricians have a lot of power to improve childbirth experiences and outcomes for patients and their clients. We have a lot of power just by simply assisting patients to make decisions for themselves and for their babies. And we know through the literature that outcomes are better when we share decisions with patients. So what we did was we set out to try to understand how OB residents and midwifery students learn, understand, and apply shared decision-making in their training. And we know that shared decision-making is essentially just a bidirectional flow of information between the physician and the patient. And this direct bidirectional flow promotes collaboration and discussion. So the care ultimately improves when decision-making is shared. Unfortunately, there isn't really a lot of established standardized training for the way that we help students and residents obtain this skill. So we wanted to sort of explore why that is and how students on the ground are learning this skill. Unfortunately, shared decision-making gets lumped into communication skills training most of the time, and I think really it might deserve its own sort of arena. So we used a constructivist grounded theory methodology as part of my master's thesis requirements, and we used convenience, purposeful, and theoretical sampling from July 2019 to September 2019. We interviewed 5 OB residents, senior OB residents, and 5 senior midwifery students. We used semi-structured interviews ranging from 30 to 90 minutes in length. We used in vivo 12 to help organize the codes, and we used open, focused, and theoretical codes, and we used constant comparative analysis to analyze the data. So when we looked at the data, really 3 sort of stages of learning emerged as per the participants of the study. They described the process of absorbing shared decision-making and the process of mirroring it back and performing it in sort of the middle to later stages of their training. They also talked a lot about how the 3 stages of learning really hinge on the level of support that they receive from their mentors. And so the theory that emerged from the data is really just, it highlights how Bandura's social cognitive theory can be used to describe the process of learning shared decision-making. Bandura's theory fits well because it really talks a lot about the complex process of negotiating the learner's environment, their behavior, and their cognitions throughout their training. And this is what Bandura calls reciprocal determinism. So when the learners were consolidating their shared decision-making, they had a really hard time putting into words what that process looks like. They talked a lot about just ongoing observation, experience, and deliberate practice. when you think about Kolb in 1984, his experiential learning theory, he talks a lot about learning spirals. And so the residents and the midwifery students talked a lot about going through this learning spiral where they absorb and they mirror and they perform it. But they really talked a lot about how it was very unstructured and it was very informal. And so they described their learning in a few different ways. One way is that they talked a lot about their environment and how it's very much a byproduct of their level of psychological safety and the hierarchy of power at the institution. So they reported learning a lot about what to say to patients, how to approach subjects, just simply by looking at vicarious positive and negative reinforcement. So they really watched how each other was treated, and which discussions were reinforced and which were they were sort of penalized for. And so the level of support they received from their mentor in regards to these discussions is really what kind of sped up the learning process for them. And they talked a lot about how shared decision-making learning is really just not very systematic. They used words like, or sentences like, we learned it through osmosis, or we learned it through fumbling through. They really didn't have any solid foundation of knowledge regarding what types of shared decision-making models exist, or even just which frameworks might be useful when approaching patients. And they talked a lot about really needing support in that. And so for the residents, they used their co-residents for support. They reported that the support they received from the consultants was very mixed. Some were very supportive, some really just, they didn't feel like they could approach at all. Midwifery students, it really came down to the quality of the mentor as well. They just felt like they weren't really able to approach all of their mentors with some of these discussions. And so some of the recommendations, there were many recommendations that came out of the study, but some of the recommendations included learners really just wanting someone to model shared decision-making, not just one time, but they kind of really just appreciated watching other people model these discussions, especially the high stakes discussions or the more important high risk discussions. And they talked a lot about how they really need to have a foundation of knowledge before they have the discussion. So a lot of times they would sort of be thrown into the discussion and really felt like they couldn't really have the discussion. So even just having training for mentors and preceptors on how to model shared decision-making, but also on just Miller's pyramid, the whole notion that you can't really show someone how to do something before you know how to do it. So they struggled with that. And a lot of it just came back to what we already know, which is that the hierarchy of power in medical education, midwifery education, can be very problematic sometimes for learning. And they really just felt like it was hard to go out on a limb and have this discussion without feeling safe in doing that. And they thought about how they might want to learn this in the future. And they felt like reflection and active discussion was super helpful for them. Hearing from patients was super helpful for them. Getting feedback, using exemplars and scripts, they reported was really helpful. And possibly using, standardized patients as many are used in communication skills training. And so I could go on and on about some of the really cool things that they reported in learning. But I think moving forward, for me personally, I think it would be really helpful to explore the effects of a more structured shared decision-making training, personally in obstetrics and midwifery, just because there are so many critical conversations that need to be had. And there's a lot of nuances around how to have those discussions. And I think it would be really interesting if there was a way that we could teach this and support mentors to do this in a more efficient and systematic way, just so that residents and students may be able to build that confidence more earlier in their training and possibly fine-tune that skill before their final year. And so I'd like to just acknowledge my thesis committee, Dr. Liz Darling, Dr. Beth Murray Davis, Dr. Sandra Montero, and Dr. Val Mueller. Thank you.
Thank you very much, Megan. That was really interesting. Are there any questions from the audience? I think we have time for just one. And I might ask a little bit about what your perception of the hidden curriculum is here, just because obviously there's going to be, you mentioned hierarchy, and hierarchy to me really just brings back that idea of what they're learning or absorbing passively as culture. I don't know if you can maybe speak to that.
Yeah, I think it's hard to say with this particular institution that we looked at. There was definitely, the culture was a big part of it, and they talked about that. And I think from what, it was interesting because I asked them specifically about shared decision making, but what I got was a whole bunch of other data about what is helpful for learning and what is not helpful for learning. And so I think, you know, as much as it was very, I think almost shared decision making was the vessel in which they wanted to address other hidden curriculum issues. So it's hard. I was kind of looking for them to tell me specifically what they needed to learn this skill, but what they told me was much more systemic and much harder to address, I think, than just shared decision making. But yeah, it was definitely, there was definitely a lack of support. Even just time spent with residents was very minimal.
Thank you very much for that. All right. For our next presentation, we have, it looks like two presenters, Anna Oliveira and Sarah Wojtkowski, and they'll be presenting factors influencing readiness for interprofessional education and health science students. So I'm just gonna,
There we go. Thank you so much. Good afternoon, everyone. My name is Anna Oliveira. I am the research coordinator for the program for interprofessional practice, education, and research at Faculty of Health Sciences. Unfortunately, Sarah could not be present today, but I'll do my best to try to explain what we did. So today I'll be presenting a work titled Factors Influencing Readiness for Interprofessional Education in Health Science Students. And we decided to conduct this evaluation because previous studies have been showing that interprofessional education improves health practitioners' collaboration, reduces clinical errors, and increases patient satisfaction. And thus, interprofessional education is now included in programs' curriculum. However, research has also shown us that interprofessional education is only effective if the students are willing and ready to engage in cooperative learning with others. And different reports in several health science students cohorts had showed different levels of readiness for interprofessional education. However, up until now, factors influencing readiness are unknown, and this, of course, limits the opportunities to target interprofessional education experiences for the most appropriate audiences. So our aim here was to explore if easy to measure social demographic data such as age, gender, level of learner, meaning graduates versus undergraduate students, previous interprofessional education experiences, and in this particular case, the cohort here in which we assessed 2019 versus 2020, significantly affect the readiness for interprofessional education in our first year health science students at McMaster. So you will see in the methods now that since September 2019, Piper has been conducting an evaluation of first year students' readiness for interprofessional education. And we currently have cross-sectional data from two cohorts, the 2019 and the 2020. In total, 2,069 students from multiple graduate and undergraduate courses, as you can see in table 1, such as physiotherapy, occupational therapy, medicine, etc., were invited to participate. In data collection, you will see that a questionnaire was distributed to the students, and I've said that in a previous presentation, but I'm going to repeat in case you were not here before. We used the quizzes function on Avenue to Learn, and we included socio-demographic questions such as age, gender, level of learner, previous experience with interprofessional education, and also the year of the cohort. Finally, students were asked to fill in the readiness for interprofessional learning scale, and I will call it ripples moving forward. The ripples is a 19-item scale with a total score ranging from 19, which indicates lower readiness for interprofessional learning, to 95, which indicate high readiness. This questionnaire is composed of 4 subscales, being those teamwork and collaboration, negative and positive professional identity, and finally, roles and responsibilities. And it has been widely validated and used to assess readiness for interprofessional education with multiple health science students and also in different contexts. So as we were interested in exploring what variables affect readiness for interprofessional education, we used a multiple regression analysis with a stepwise model, where the dependent variables or the variable that was going to be predicted was the RIPPLE scores, and the independent variables or the predictors were, as I said before, age, gender, level of learner, previous interprofessional education experience, and the cohort here. Now, moving to the results in the right part of the slide, you'll see that from those invited, 885 participated, and this corresponds to a 42% response rate. Our responders were mostly females, aged approximately 22 years old, and with little interprofessional education experience. Now, the main message here, I think, comes right before our table, and is that all of these variables that we included in the model only explained less than 30% of the variability in the RIPPLE scores. And only age, graduate level, and here of cohort were able to explain the variability in our student scores. Now, table 1 here presents the individual contribution of each variable in explaining the variability, but I'm not going into too much detail in this table. I just want to highlight that we can see from the beta here that overall the cohort here was the variable that most contributed to explain the variability. And if we look at the B, in fact, the total score for the total score students from the 2020 cohort scored approximately 9 points lower than those from the 2019 cohort. Now, after the table, you'll see that gender and previous interprofessional education experience did not contribute to explain the variability in the scores. So we can overall conclude that age, graduate level, and academic year influence readiness for interprofessional education in our cohort, and that older and graduate level students from the 2019 cohort typically expressed greater readiness for interprofessional education. Obviously, from the great contribution of cohort here to explain the variance, it kind of made us think that, or about the effect that online learning, specifically for the 2020 cohort, the effects that this might have had to the interprofessional experiencing readiness. And finally, since the variability explained by the factors in the model was less than 30%, we think that we might have been missing here some very key factors to explain the variability. And we were thinking, for example, about how prior healthcare or health sciences degrees or experiences might have influence in this readiness for interprofessional learning. Moving forward in our survey, so we are going to continue to apply these surveys, and we will also include, hoping that it will allow to get us a better grasp on this variability, we'll also include all of these questions that I mentioned. Thank you so much for assisting to this presentation, and I'm happy to answer any questions you might have now.
Thank you so much for that. Any questions from the audience? Can I ask, and maybe this is total speculation, but can you propose a reason, a mechanism why older graduate level students might be more ready for interprofessional practice? Is there an idea that's going to translate to your next survey, for example?
Yeah, thank you so much for the question. Yeah, that was also something that we thought about. And we thought that maybe these people that were older could have had other experiences of interprofessional, not specifically education, but interprofessional experiences overall that might cause them to be more ready. And that was why we were thinking about including in the next surveys more specific questions about, do you have any other degree in health sciences? Or do you have any other experiences outside education that lead you to interprofessional encounters? And that might kind of explain that. So these folks were older and probably had more chances to experience that. Yeah, and that is what we are doing moving forward.
Okay, thank you very much for that. Just as a side note, you got a comment here from Anita, who talked about how she thought your poster was very nice, just the message right in the middle.
Oh, thank you so much, Anita.
Okay, thank you. So let's move on to our last presentation. Kestrel McNeil will be presenting musculoskeletal knowledge assessment of medical trainees and the impact of clinical experience.
Hello, everyone. Can you hear me okay?
Yes.
Okay. So my name is Kestrel. My pronouns are she and her, and I'm a master's student in health research methodology at McMaster. So this work is actually part of my thesis that I'll be defending soon, so I'm extremely excited to share this with all of you. I was able to complete this work with the help of the Office of Education Science in the Department of Surgery and the Orthopedic Clerkship Director at McMaster, Dr. Devin Peterson. So musculoskeletal or MSK instruction has been identified as being inadequate in undergraduate medical education around the world. So just over 2 decades ago, there began to be a recognition that medical learners were emerging from their training lacking in both sufficient confidence and knowledge to manage MSK conditions. So this was reflected in low passing rates on validated MSK knowledge assessments and in various evaluations that reported that primary care physicians, residents, and medical students generally had low confidence in their ability to accurately diagnose as well as treat MSK-related complaints. These gaps were very, very quickly linked back to problems at the undergraduate level of training, and barriers to implementing comprehensive MSK instruction were identified as primarily being a lack of time and resources dedicated to this subject area. It was also identified that a lack of clinical opportunities and foundational instruction gaps were also contributing to this lack of confidence. So after the gaps in undergraduate MSK curricula were identified, there began to be more and more examples of concentrated curricular form in countries such as the United States and Australia. So despite there being some evidence that Canadian medical schools suffered from similar problems, there really haven't been many attempts to evaluate or address the specific gaps that exist within our MSK curricula in Canada. So last year, we assessed the DeGroote School of Medicine's MSK curriculum using qualitative interpretive description, engaging both students and orthopedic faculty members, and found similar challenges to those that have been identified in other countries. So this included limited clinical opportunities and time dedicated to foundational instruction, as well as low motivation for students to learn MSK anatomy and gaps in MSK anatomy as a whole. So many students also suggested that these gaps actually contributed to them feeling unprepared to enter their orthopedic clerkship rotation. So the purpose of this present study was to assess orthopedic clerks' MSK knowledge at the beginning and at the end of their rotation, and in order to determine whether clinical exposure to MSK conditions positively impacted their MSK knowledge. This study also sought to validate or support our qualitative findings and assess whether or not this general feeling of unpreparedness described in our past study was reflected in students' MSK knowledge at the beginning of their orthopedics rotation. This was accomplished by conducting a repeated measures study or a pre-test, post-test design. This study is actually part of the quantitative strand of a broader sequential exploratory mixed methods approach, but I'll just be focusing on the quantitative results for the purposes of this presentation. So we tested orthopedic clerks pre-rotation and post-rotation using 2 different MSK knowledge assessments. Essentially, the pre-test was conducted on day 1 of the orthopedics rotation, and the post-test was conducted on day 14 at the end of the rotation. These 2 knowledge assessments that were used for the pre-test and the post-test were constructed using validated examinations and were also constructed in consultation with an orthopedic content expert. So each test was composed of a mix of 20 short answer and multiple choice questions, which asked about MSK topics from both orthopedics and primary care settings, including fractures and dislocations, emergencies requiring immediate orthopedic referral, basic anatomical knowledge necessary for the diagnosis of MSK conditions. It also included trauma, infection, pediatric-specific MSK conditions, as well as sports injuries. So a score of 71.3% was deemed as being the benchmark for basic competency based on previous studies within the subject area. A paired t-test was used to determine whether students demonstrated a significant increase in MSK knowledge between the pre-test and the post-test, and McNamara's test was also used to determine whether there was a significant difference in the proportion of students who met this basic competency benchmark at the beginning versus at the end of their orthopedic clerkship rotation. A total of 53 clerks completed these assessments from January to March of this year. So when we analyzed the data obtained from the pre-test, the average score was 57.6%. And of the 53 clerks, 48 or 90% of them actually fell below the basic competency score of 71.3%. Only 5 students scored above this benchmark prior to the start of their orthopedic rotation. So in contrast, the average post-test score was actually 80.5%, and the 95% confidence interval spanned from 78.1 to 82.9%. Only 6 students fell below this basic competency score at the end of their rotation, and 47 or around 89% of students actually passed this benchmark. So on average, students actually demonstrated a 22% increase in their MSK knowledge assessment scores. So this represented a significant difference based on the paired samples t-test. And also there was a very obvious significant difference in the proportion of students who met this basic competency score of 71.3% pre and post rotation. So as you can see from the table presented on this slide, the high proportion of students passing the basic competency benchmark post-rotation is a stark contrast to the passing rates demonstrated pre-rotation. So overall, these results support our findings from our qualitative work, which indicated that students were entering their orthopedics rotation with significant gaps in their MSK knowledge. On the other hand, we also demonstrated that their time in orthopedics, although only being very short and 2 weeks in length, positively impacts their MSK knowledge. So this ultimately illustrates the importance of providing students with opportunities to be exposed to MSK conditions in clinical settings to ensure that they're gaining sufficient experience in the subject area. This is only going to become more and more important as our aging population contributes to the already heavy burden of MSK conditions on our healthcare system. So we're currently evaluating whether adding a self-directed learning tool to the orthopedics rotation can further augment students' clinical experiences and improve their MSK knowledge assessment post-rotation. So the aforementioned qualitative study informed the development of this learning tool, which spans 4 key areas of common soft tissue injuries, common fractures, orthopedic red flags and emergencies, as well as pediatric orthopedics. So this learning tool is composed of a series of online modules and learning objectives, as well as self-assessment activities. And we will be using the study's population as the control group and hope to expand the use of this learning tool to other settings beyond the orthopedic clerkship rotation if it's deemed as being successful. So thank you for listening, and I hope you enjoyed this presentation.
Thank you very much, Kestrel. Any questions from the audience?
Hi, I have 2 quick questions.
Yes, please.
Thank you, by the way, Kestrel, that's great. Can you tell me a little bit more about your pre-test and post-test? Were they essentially the same questions, or was it drawn from a random bank?
They were drawn from a random bank. So I had orthopedic surgeons review them to make sure that I wasn't essentially testing the same or using the same questions pre and post-test, because obviously that would pose some issues in terms of the validity of the design, but they were within the same general content area. So we made sure to match, we had one question in the pre-test about an upper extremity fracture. We would ask another question about an upper extremity fracture, but within a different area, testing a little bit of different knowledge. So they were within the general content area, but a little bit different.
Okay, and so I'm sitting on your defense, and I ask you this question. What about students who didn't do the rotation but just took the test, like a control? How you don't have one, but how do you justify that?
So students who didn't do the ortho rotation at all?
They just did the test. We know test really drives knowledge, right? One of the best ways to learn is to test somebody.
Right.
So how do we know that the rotation did all this difference and not the fairly considerable effect of testing on learning?
That's a great question, and it's something that we have kind of considered in a portion of the research that we're doing for my defense. I didn't have time to go into it, but we're asking about the effect of clinical experience in qualitative interviews as well as surveys to see whether or not this testing was what actually drove the learning, or if it was the orthopedic clerkship rotation, because obviously it's very difficult to tell from just this data.
Great. Well, thank you very much. That was actually very insightful. Those questions really helped clear up some of that as well. So it is now 12:50. Thank you to all the presenters for the hard work and the presentations that you did. Very high quality work here. If you have any questions for any of the presenters afterwards, please, you'll be able to find their contact information through the syllabus, but also you can contact us and we can get in touch with you if you have any further discussions. Otherwise, the closing remarks are starting right now. So thank you again, and we'll see you over in the main room.